Dear students, today we'll discuss regarding National Filaria Control Program. In your syllabus, National Health Program in unit number 6, National Filaria, you can see National Filaria Control Program. So, before going to the National Control Program, so just we will review the filaria, what is filaria and what are the organisms and what is epidemiological factors includes in filaria. The term lymphatic filaria covers the infection with three closely related nematode worms, namely Filaria bancrofti, Brugia malai, Brugia timori. That means it is a nematode worms infection. All three infections are transmitted to men by the bites of infected mosquitoes. So, filariasis is a global problem and it is a serious public health problem in India. The disease is endemic all over India and it is low degree of transmission in Jammu, Kashmir, Himachal Pradesh, Punjab, Haryana, Delhi, Chandigarh, Rajasthan, Nagaland, Manipur, Tripura, Meghalaya, Sikkim, Arunachal Pradesh, Mizoram and Dadra and Nagar Haveli. And it is heavily infected in areas such as Uttar Pradesh, Bihar, Jharkhand, Andhra Pradesh, Orissa, Tamil Nadu, Kerala and Gujarat. So, regarding epidemiological determinants, there are three factors associated to epidemiological determinants. That is, number one is agent factors. Agent factors means mainly the organism, three nematode worms such as Filaria bancrofti, Brugia malai, Brugia timori, and the vectors. Vectors mainly Culex mosquitoes and Anopheles mosquitoes. So, under the host factors, man is a natural host and it affects all ages including infants. But in case of man it is higher than the female and it is also leads to extension in case of migration. And regarding immunity, resistance develops after many years of exposure. So, some of the social factors also associated regarding this filariasis, such as urbanization, industrialization, migration, literacy, poverty and poor sanitation. So, under the environmental factors, the climate is the most important factors and the temperature is 22 to 38 degree centigrade and humidity also 70%. And poor drainage facilities, lack of town planning, inadequate sewage disposals are associated with these filarial infections. Regarding mode of transmission, the infection is transmitted by the bite of infected vector mosquitoes. Incubation period is 8 to 16 months. Now comes to the clinical manifestations. It is asymptomatic amicrophilaria, asymptomatic amicrophilaria and asymptomatic microfilaria, stages of acute manifestation, stages of chronic obstructive lesions. These are the stages associated with clinical manifestations in filarial disease. So, as regard in the stage of asymptomatic amicrophilaria, the patient does not show any clinical manifestations even after exposure to the disease. In the stage of asymptomatic microfilaria, the blood of the infected person is positive for microfilaria, without any symptoms. That means the blood is positive. If you test for the infected person's blood, it is positive with microfilaria, but there is no symptoms expressed in that man. So in the stage of acute manifestations, in the first months, acute inflammation in lymph glands and vessels occur. Filarial fever, lymphangitis, lymphadenitis, lymphedema of various parts of the body, epididymoorchitis in male. These are the manifestations, or these are the clinical symptoms occurs in this stage of acute manifestations. Then in the stage of chronic obstructive lesions, which develops after within 10 to 15 years from the onset of the first acute attack. Means after acute attack, these stages developed from the 10 to 15 years from the onset of this acute attack. So fibrosis and obstruction of lymphatic vessels occurs, causing permanent structural changes. So these are the clinical manifestations occurs in filarial disease. Regarding control of filarial infections, the current strategy includes chemotherapy and control of vector. Under the chemotherapy, diethyl carbamazine is used, which can be administered as preventive chemotherapy, selective treatment, or diethyl carbamazine medicated salt for mass use. So for vector control, antilarval measures can be used, which includes elimination of breeding places, anti-edal measures of pyrethrum as a space spray, personal prophylaxis, that means avoiding bites of mosquitoes. Under the National Filaria Control Program, this National Filaria Control Program has been in operations since 1955. In June 1978, operational component of the National Filaria Control Program was merged with the Urban Malaria Scheme for maximum utilization of the available resources. That means in the year 1978, this National Filaria Control Program was merged with the Urban Malaria Scheme for a maximum utilization of the available resources with both the disease. But the training and research components of this program, which was continued with the Director, National Institute of Communicable Disease, Delhi. So the disease is endemic in 255 districts in 16 states and 5 union territories. About 630 million people are exposed to the risk of infections. So regarding the training centers for training in filariology, there are 3 regional filaria training and research centers under the National Institute of Communicable Diseases in Delhi. So these are located in Kerala, Andhra Pradesh and Uttar Pradesh. So regarding program implementation, the program is implemented in endemic urban towns, includes 206 filaria control units, 199 filaria clinic and 27 survey units. And in the rural areas, the program is implemented by use of anti-filaria medicine and management of morbidity through primary health care. The lymphatic filariasis elimination. In India, National Health Policy 2002 envisages elimination of lymphatic filariasis by 2015. The elimination is defined as lymphatic filariasis ceases to be public health problem when the number of microfilaria carriers is less than 1% and the children born after initiation of elimination of lymphatic filariasis are free from circulating antigen anemia, presence of adult filaria, that means presence of adult filaria worm in human body. So this is known as elimination of lymphatic filariasis. The strategy for elimination includes annual mass drug administration of single dose of antifilarial drug for 5 years or more to the eligible population except pregnant women or children below 2 years of age and seriously ill persons, and home-based management of lymphedema cases and upscaling of hydrocele operations in identified community health centers, district hospitals or medical college. In 2004, Government of India launched annual mass drug administration with single dose of diethyl carbamazine tablets in addition to scaling up home-based food care and hydrocele operation. In 2007, co-administration of diethyl carbamazine plus albendazole initiated. The coverage has improved from 72% to 72.4% to in 2004 to 86.8% in 2014. So these are about the National Filaria Control Program. So next comes to the National Guinea Worm Eradication Program. Guinea worm disease is caused by the parasitic worm Dracunculus medinensis or Guinea worm. This worm is the largest of the tissue parasitic affecting humans. The disease is seasonal. Transmission generally occurs in the rainy season, that means from May to August. Epidemiology, which is determined largely by the use of open stagnant water sources such as ponds and sometimes shallow or step wells. Human made ponds are the main source of transmission. The parasite is transmitted mostly when people drink stagnant water that is contaminated with parasite infected water fleas. Incubation period for Guinea worm that is 10 to 14 months. Eradication program in India was started in 1983 to 84 in 7 endemic states includes Tamil Nadu, Gujarat, Maharashtra, Andhra Pradesh, Kerala, Madhya Pradesh and Rajasthan. So symptoms includes no symptoms for about 1 year. Then the following symptoms are developed gradually: slight fever, itchy rash, nausea, vomiting, diarrhea, dizziness. Blisters develop in anywhere on the skin. Blister gets bigger over several days and causes burning pain. The blister eventually ruptures and exposing the worm. So National Eradication Program, India launched this program in 1984 with technical assistance from World Health Organization. The program is integrated with the national health system at village level. The country has reported 0 cases since August 1996. That means there is no Guinea worm cases in India. In February 2000, the International Commission for the Certification of Dracunculiasis Eradication recommended that India be certified free of draconiculiasis transmission. That means India is certified that there is no draconiculiasis in transmission or guinea worm infestation or infection in India. That means India is free from guinea worm infection. The activities are continuing as per recommendations of International Commission for Certification of Draconiculiasis Eradication. The health education with special emphasis on school children in rural areas. That means you have to, as a public health nurse, you have to continue the health education regarding this guinea worm infection or infestation from beginning of the school children in rural areas. Rumor registration and rumor investigations. These are the national program. The maintaining of guinea worm diseases on list of notifiable diseases and contamination of surveillance in previously infected areas. Careful supervision of water sources whenever necessary, as it is the water means infection is transmitted through drinking of stagnant water and it's infected water. So you have to supervise carefully the water sources used in different areas or localities, mainly in rural areas. So these are about the guinea worm eradication program nationally. Next comes to the US eradication program. US, the disease has been reported in India from the tribal communities living in hilly forest and difficult to reach areas in 49 districts of 10 states, namely Andhra Pradesh, Assam, Chhattisgarh, Gujarat, Jharkhand, Madhya Pradesh, Maharashtra, Orissa, Tamil Nadu and Uttar Pradesh. The program is implemented by the state health directorates of US endemic states utilizing existing healthcare delivery systems with the coordination and collaboration of Department of Tribal Welfare and other related institutions. The number of reported cases has been come down from more than 3,500 to nil during the period from 1996 to 2004. Since then, no new case has been reported. See, students, you just remember that these are the national health problems in India, and under these national health problems, the EOS and the guinea worm already has been eradicated from the India. Still, you have to remember that these are the health problems in India. So now next comes to the minimum need program. Minimum need program is the expression of the commitment of the government for the social and economic development of the community, particularly the underprivileged and underserved population. It was introduced in the first year of the fifth 5-year plan, that means in the year 1974 to 78, with the objectives of to improve certain basic minimum needs and thereby to improve the living standards of the people. That means the objectives of the minimum need program was to improve the basics, some of the basic needs, minimum needs, and thereby to improve the living standards of the people. The program includes rural health, rural water supply, rural electrification, elementary education, adult education, nutrition, environmental improvement of urban slum, houses for landless laborers. So principles of minimum need programs, there are two basic principles to be observed in implementations of the minimum need program. Number 1 is the facilities under minimum need program are to be first provided to those areas which are at present underserved so as to remove disparities between different areas. Second one is the facilities under minimum need program should be provided as a package to an area through intersectoral area projects to have a greater impact. In the field of rural health, the objectives of the minimum needs program supposed to be achieved by the end of 8th 5-year plan. Under the minimum need program were one primary health center for 30,000 population in plain areas and 20,000 in tribal and hilly areas, one sub-center for 5,000 in plain areas and 3,000 in tribal and hilly areas, one community health center for 1 lakh population. And the establishment of primary health center, sub-center and community health centers, upgradation of primary health centers, construction of buildings thereof are all included in the state sectors of minimum need program. So these are regarding the rural health. In the field of rural health, means in the field of rural health, you have to think and you have to consider the rural health development, and rural health services should be provided under the primary health center and sub-center and community health centers. So next comes to the in the field of nutrition, what are the minimum need programs under the field of nutrition? The objectives are to extend nutrition support to 11 million eligible persons, to expand special nutrition program to all ICDS projects, to consolidate the midday meal program and link it to health, potable water and sanitation. These are the objectives under the field of nutrition. So these are regarding the minimum need program and the principles of minimum need program. So it may comes in the exam as short note. So please try to understand the minimum need program first, then you have to remember what are the minimum need programs and what are the basic principles for implementation of the minimum need program. You have to write down all these points point wise for short note. Next comes to the 20-point program. In addition to the first 5-year plans and programs in 1975, the Government of India initiated a special activity. This was the 20-point program, described as an agenda for national action to promote social justice and economic growth. On August 20, in the year 1986, the existing 20-point program was restructured. Its objectives are spelled out by the government as eradication of poverty, raising productivity, reducing inequalities, removing social and economic disparities, and improving the quality of life. At least out of 20 points, 8 are related to health, maybe directly or indirectly. So these 8 points are number 1, point number 1, that is attack on rural poverty. Point number 7, clean drinking water. Point number 8, health for all. Point number 9, 2-child norm. 10, expansion of education. Number 14, housing for the people. Number 15, improvement of slum. Number 17, protection of the environment. So these are the 8 points out of 20 points are related to the health. Over the years, it is felt need for restructuring the program and the inclusion of various new policies and program by the government. See the students, see that these are the minimum need program which was first initiated in the India in the year 1975, and it was restructured in the year 1986, and again it is restructured in the year 2006. So it was felt need for restructuring the program for inclusion of various new policies and government programs. This restructured program, that is called 20-point program 2006. 20-point program 2006. It was approved by the cabinet on 5th October 2006 and implemented with effect from 1st April 2007. So list of 20 points to 2006 includes poverty eradication, power to people, that is Janashakti, support to farmers, that is Kishan Mitra, labor welfare, that is Shramik Kalyan, food security, Khadya Suraksha, housing for all, that is Sabke Liye Awas, clean drinking water, that is Shuddha Piye Jal, health for all, means Jan Jan Ka Shastha, education for all, Sabke Liye Shiksha, welfare of scheduled caste, scheduled tribe and minorities and OBCs. Then next, women welfare, that is Mahila Kalyan, child welfare Bal Kalyan, youth development Joba Vikas, improvement of slums Basti Sudhar, environment protection and afforestation, social security, that is Samajik Suraksha, rural roads Gramin Sadak, energization of rural areas, that is Gramin Orja, development backward areas, that is Picharakstra Vikas. Picharakstra Vikas. Point number 20, that is IT enable e-governance, that is e-Shashan. E-Shashan. These are the 20 points that are restructured in year 2006. So students, today we have discussed so many things according to your syllabus. These are all related to the national health programs, and there are so many national health programs, but you have to study all, and you have to please study all this national health program very carefully, and last of all you have to just write down what are the role of nurse in national health programs. Okay, thank you. Study hard, study well, stay safe at home. Thank you.